Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center. Welcome to our Monday afternoon Instagram chat. Since I'm isolated here in my office, I'll get rid of my mask and keep you guys safe by video distancing. At any rate, today's topic is understanding PGT, or embryo biopsy. And the first thing to understand is the terminology. PGT stands for pre-implantation genetic testing. And what we're doing with pre-implantation genetic testing is biopsying the embryo from an IVF cycle at the blastocyst stage of development, which is usually on the 5th or 6th day of embryo development. And then we have the opportunity to freeze that embryo, and from the biopsy of a few cells from the outer surface of the embryo, the future placental cells, we can ask this embryo some basic questions about the health of this embryo. And if one looks historically at embryo biopsy, 5 or 6 years ago, we used to do embryo biopsy on the 3rd day of development, and there were very limited ability to analyze chromosomes. We did it with techniques that would not be able to look at the whole genetic complement of 23 sets of chromosomes. And with the advent of next-gen sequencing, where you can look for thousands of genes and to assess whether there's large deletions or duplications or missing chromosomes, it's become much more accurate. And by biopsying the embryo on the 5th and 6th day of development as a blastocyst, when an embryo has between 50 and 100 cells, rather than when an embryo only has 6 or 8 cells, makes a big difference on the safety of it and how invasive this is to the embryo itself. The big advantage of biopsying on the 5th and 6th day rather than earlier is that we've already seen a differentiation between the cells that form the inner cell mass of the embryo that become the actual fetus, and the surface cells around the outside of this embryo, which become the placenta. So we're actually biopsying future placental cells, and you try and biopsy 5 to 10 cells to have enough DNA to do an adequate analysis. So technically how this is done on the 3rd day of development, using a microscope and a laser, the shell around the outside of the embryo, the zona pellucida, has a little microscopic hole placed in it. And then as this embryo begins to continue to expand and multiply, some of the cells on the surface that are right under that little opening will kind of pouch out. And then again, with the laser, you can cut off a small grouping of cells from the placental tissue, future placental tissue, the surface cells around the embryo, and you can send those for genetic testing. There are 2 types of genetic testing that we can do. And as time goes on, if we look back on this talk today in 5 or 10 years, I think this is going to be an archaic talk. I think the ability of what we can look at is going to be so much more advanced and give us so much more predictive value for embryos than what we have now. But what's available today are 2 basic things. The first and the most common use of pre-implantation genetic testing is for aneuploid screening. It's basically asking the question, does this embryo have the correct number of chromosomes present? And by analyzing thousands of genomic sequences, one can assess whether the embryo is euploid or aneuploid. And in a black and white world, it's either normal or abnormal. A euploid embryo has 23 sets of chromosomes. It has 2 copies of each chromosome. With the sex chromosomes, it'll have 2 sex chromosomes, and it will be able to distinguish whether you have 2 X chromosomes or 1 X and 1 Y chromosome. And obviously that is important if you want to know gender, or even doing this to choose gender, so you can identify which one's a male and which one's a female. It tells you that the embryo has the correct number of chromosomes, and with 98% accuracy, it's going to do that. Why isn't 100% accuracy? Because you might not be able to diagnose very small, what are called deletions in chromosomes, where if it's missing a piece of DNA, but the number of base pairs is very, very minimal, it might not pick that up unless you were specifically looking for it ahead of time and know what you're looking for. So in general, PGT is 98% accurate. It will tell us if you're doing it for aneuploidy testing, it's called PGT-A. A is for aneuploidy. And the hope is that we get a large number of euploid, which are normal embryos. The incidence of aneuploidy, of abnormal embryos in a given cohort of embryos, depends largely on the ovarian reserve of the person whose eggs it came from and the age of that person. And in general, if you look at women that are 30 years and younger, even in a normal young person, the incidence of abnormal embryos is going to be about 30%. And this occurs naturally, and it occurs in an IVF arena. The IVF process itself does nothing to increase the risk of aneuploidy. You get the same incidence of normal and abnormal embryos, whether you conceive naturally or it occurs in the dish. The difference is that abnormal embryos that are very abnormal rarely develop. So even if they get to the 5th or 6th day of development, when we're biopsying them, naturally they may implant for a couple of days, but it then stops developing. You get a period. If you don't get a period, the most common fate of an abnormal embryo is that you miscarry, and the least likely thing to occur is you have an abnormal baby, like a Down's baby or something of that nature. The incidence of aneuploidy in general, 30% for women under 30. At age 35, we're going to see a 50-50 split between normal and abnormal embryos. At age 40, it's going to be about 70% abnormal, and at age 42, 85% of the embryos are not going to be normal. And this helps explain why it's more difficult for women that are older to get pregnant easier, and why the miscarriage rate is higher in patients as they age. So pre-implantation genetic testing for aneuploidy tells us if we have the correct number of chromosomes or not. It'll show a large deletion or portion of a chromosome being missed, but it tells us nothing specific about that embryo, other than it has the correct number of chromosomes. The second type of genetic testing is done the same exact way. You're taking a biopsy of the embryo, and in addition to looking for aneuploidy, we can also look for what's called the single gene mutation testing. In this case, it's referred to PGT-M, that stands for gene mutation testing. And with this particular approach, we have to know what we're looking for ahead of time. In all of our patients, we recommend doing pre-conceptual genetic testing. We do a blood test, and with that blood test, we're checking to see whether you're a hidden carrier for 287 different diseases. Let's choose one of them, for instance, cystic fibrosis. This is an autosomal recessive trait where if you're a carrier for it, you don't have any symptoms, you don't even know you're a carrier for it. It's only a problem if both you and your partner are both carriers for this abnormality or any abnormality that's transmitted in this fashion. And in that scenario, you'd have about a 25% chance of having an offspring that would be affected by the disease. So in patients that are coming to us for fertility management, we have the distinct advantage that we can do these tests before you try and get pregnant, rather than a situation where a couple comes in, and we have this occur. A patient comes in and says, I want to have IVF and genetic testing. We go, why? And they go, well, unfortunately, I had a baby with cystic fibrosis, and I don't want to have another one. And so, unfortunately, because some babies are normal, some are abnormal, it could be a hidden trait that you never see. And as a result of that, you get a surprise, which is not a good surprise, and you get a bad baby. And now there's nothing you can do about it. But you can prevent it in the future by testing the embryos for that. So let's assume we have this condition of cystic fibrosis, or condition X, whatever it might be. And that's to find out whether you're a carrier for a disease. We test the parents. We test the mother and the father. In our lab, we use a genetic screening test called a SEMA 4 panel, SEMA number 4 panel. And this just looks to see whether you're a carrier for 287 diseases. You can think of it as a medical glorified version of 23andMe. It tells you nothing about ancestry, just tells you, are you at risk of having a problem if your partner were to carry the same mutation? In a situation where you're both carrying an abnormal gene, in that case, we want to be able to test the embryos to see if they're normal or not. So to do that, we have to obtain DNA from both parents, and that's usually done with a buccal swab, salivary DNA basically, that comes from the cheek and the mouth. And the genetics lab that we use will take the DNA of the mother and the father that are carrying this abnormal gene, and they will develop what's called a probe that will be available to be able to identify the DNA that's normal, the DNA that's a carrier, and the DNA that is affected. And so if we know that we're looking for a specific abnormality, we need to be able to create this probe. Unfortunately, we can't biopsy an embryo and test it for 287 different things. That technology doesn't exist. But if we know someone's at risk for a problem, we can develop the probe for that abnormalities. In this case, let's say the cystic fibrosis gene mutation that's present in the parent. And then when we have the embryo biopsy, the genetics lab can look at both, is there the correct number of chromosomes present, and obviously the ones that do have the correct number of chromosomes are embryos available for transfer. And it can also assess whether each of those embryos is a carrier for the disease, has the disease, or is both free of the disease and is not a carrier. And the ideal scenario, the ideal embryo to put back into you is an embryo that is free of the disease and also is not a carrier. And what have you done by doing that? You've succeeded at eliminating this risk in future generations. It's also acceptable to put back embryos that are a carrier for a given disease, because if you're a carrier for such as cystic fibrosis, you don't have any problems. So there's no problem with the baby having the same scenario. It's only an issue if that child down the road 20 years decides to have a baby with somebody who's also carrying the same abnormality. So embryos that are acceptable to put back when you're doing pre-implantation genetic testing for single gene defect are, one, ideally embryos that are totally free of the abnormal gene, and two, those that are carriers for it. And those that are affected by it, we do not transfer, because that's the reason we're doing the biopsies in the first place. When you get the reports back from the genetics lab with mutation testing, it'll tell you whether it's a carrier, whether it's a free of the disease, or whether it's an affected embryo. With embryos that are biopsied for aneuploidy testing, you'll get back either this is a normal embryo or a euploid embryo. It's an aneuploid embryo. So that's the black and white answer. And then sometimes you can get two other possibilities. One is an indeterminate result. And an indeterminate result just means when they ran the assay from the limited amount of DNA that we give them, they weren't able to get a clear enough signal to determine whether the embryo was normal or abnormal. This does not mean you have an abnormal embryo, nor does it mean that it's normal. It's the same as if it wasn't biopsied in the first place, and it's just the limitations of the technology. Over 95 to 98% of the time, we get an answer one way or the other. But there are some embryos that fall into that crack where they just don't get a good enough signal. And then the question is, we prefer to leave those embryos for the last ones to transfer. We do have the option of thawing them, rebiopsying them, and refreezing them to see whether we can get a clearer answer with a new biopsy. but that process of thaw and refreeze can potentially compromise the embryo. Where the initial biopsy and freeze doesn't seem to have any effect, we worry when we're doing a second biopsy on the same embryo that may compromise it. It doesn't cause birth defects, it doesn't cause the embryo to be abnormal, it's just a matter of will it decrease the chance of that embryo surviving when we thaw it again a second time. The other thing that we occasionally will get when we do aneuploidy testing is an embryo that's described as a, quote, mosaic embryo, unquote. And mosaic embryos are the most confusing to deal with. You get back a combination of results. It's in that they analyzed the DNA, and some of the DNA was normal, and some of the DNA was abnormal. In the lab we use, high-level mosaicism is reported as mosaic, as aneuploidy, and low-level of mosaicism comes back as mosaicism. So the problem is that if you have some cells that are normal and some abnormal, is that going to be a normal embryo or an abnormal embryo? And the reality is we don't know the answer to the question. And so that becomes an embryo that's more likely to be abnormal than one that comes back normal. And the issue is, should it be transferred or not? In our program, we do not transfer mosaic embryos because of the high risk that they're just abnormal embryos. There are some mosaic abnormalities that nobody would transfer. If it's a mosaic for, let's say, chromosome 21 or chromosome 13 or 18, those result in abnormal babies. So if you're wrong, you're going to have an abnormal baby. Nobody would transfer those. There are some mosaic abnormalities that are just not compatible with life. For instance, extra chromosome 15 or extra chromosome 22. There's never been a baby born with that abnormality, so some people feel, okay, if that's the abnormality, why not put it in and give it a chance, even though the likelihood of it working is extremely low and the miscarriage rates are extremely high. If you're going to transfer a mosaic embryo, it needs to be under investigation review board, clinical study protocols, and in our private program, we don't have that available. Very few centers do, but there are some places in the country that will transfer mosaic embryos. So when we get results back of mosaic, we ask you to talk to the genetic counselor, go over it, and reach a decision what you would like us to do with those embryos. In general, the consent forms that we have give us permission to discard abnormal aneuploid embryos. Anything that doesn't fall into that category is kept until you give us guidance on what to do. And per our consents, we keep them for 6 months in the office, and then they go to Reprotect as a commercial storage facility. Euploid embryos have the best chance of successful implantation. Whether you're 41 or 33, we still recommend only transferring a single embryo to minimize the risk of multiple birth, particularly if they've been biopsied embryos. If they're not biopsied embryos, then that recommendation would change a little bit. So in summary, PGT, pre-implantation genetic testing of the embryo. There are 2 different types of testing we can do. One is for single gene mutation testing. That's called PGT-M, where we're looking for a specific disease target based on the abnormality in the mother and father's DNA. The most common form of PGT analysis is aneuploidy testing. The incidence of abnormal embryos increases as you're getting older, and the ability for us to select the best embryos to put back, minimize the risk of miscarriage, and also importantly to give you comfort that what you're keeping frozen, that you're not transferring for many, many years, you could keep them in the freezer. If the embryos are abnormal, why keep paying an annual storage fee to store them? So knowing that they're normal is beneficial in that regard, so at least you have some confidence that what's you're keeping in the freezer for use 2 or 3 years down the road has a good chance of working. So euploid embryos have the correct number of chromosomes as a result of pre-implantation genetic testing for aneuploidy. Those are the embryos that we recommend transferring. And embryo transfer with the frozen embryo is done on a thawed cycle, where we thaw the embryo at the correct time of implantation. And the timing of that is depending on when the endometrium is ready for that embryo to implant. So that's today's talk. I hope this is helpful in understanding the mechanics of the biopsy, the types of testing that are done, and which test is best. And from a practical side, most of our patients select for aneuploidy testing for the reasons that we discussed. And for those that have specific abnormalities, we get into much more detail about the single gene defects and why that's so important to test for. If you have questions, please ask your docs, ask me, ask our embryologist, ask the semaphore genetic counselor if it's related to a single gene defect. And we're all here to get you a healthy, safe pregnancy, and wish you well for the new year. Have a good day, everybody. Okay.